we should know what is uncomplicated malaria first. So we know that a patient who presents with symptoms and positive parasitological test, either it's the RTD or the microscopy, and have no features of severe malaria, then this is uncomplicated malaria. And again, the clinical manifestations of uncomplicated malaria are very non-specific. The patient can be febrile only, he can have abdominal pain, vomitings, myalgias, arthritis, तो नहीं arthalgia कहना चाहिए, and just vomiting and all these symptoms. And examination पे we can find an ecteric child who has splenomegaly or even hepatosplenomegaly. Febrile seizures can occur in uncomplicated malaria, but we should be very careful for this and take a detailed history, because it's a part of, it's a feature of complicated malaria as well. So the malaria, uncomplicated malaria again is caused by falciparum and non-falciparum species, the vivax, ovale, malaria, and the nullici. So the treatment goals for uncomplicated malaria is like any other infection. That is, cure the infection as soon as possible and prevent the progression to severe, complicated disease. And the uncomplicated malaria by falciparum, we have learned in the earlier slides that the falciparum is resistant to chloroquine now, most of the times. So we need to be careful while treating falciparum, and we usually treat the first-line treatment for falciparum, diagnosed falciparum malaria, is actually artemisinin-based combination therapies. There are few incorrect approaches for the treatment of ACTs which are leading to the resistance that we were discussing earlier as well. So the first one is the use of monotherapy. कि अगर आप सिर्फ artemisinin यूज कर रहे हैं या कोई counter medicine यूज कर रहे हैं alone, then that can cause resistance. That way as well, there were concepts that there is a partial immunity in people living in endemic areas, but now this concept has been discarded or discouraged by WHO, and they recommend a complete dose for every patient regardless of their underlying immunity status. And as discussed earlier, we were saying that giving only the first dose pending the confirmation of diagnosis is also not right. That will induce the resistance. So just make the diagnosis first and then go for it. Whatever we are discussing is being taken by these WHO guidelines, which are the modification and upgrading of 2015 guidelines. So the first guideline is the same, that artemisinin-based combination therapies should be used for the treatment of uncomplicated falciparum malaria in pediatric population as well as in adults. And we have these available medicines, which are artemether lumefantrine, artesunate amodiaquine, artesunate mefloquine, dihydroartemisinin piperquine है, artesunate sulfadoxine pyrimethamine है, and newly added, जो कि 2022 में ही add किया है, artesunate pyronidine, right? And this one is not recommended in pregnancy. So the two new things are that this one is the new added ACT, and it should not be used in pregnancy. We have only artemether lumefantrine, but just now Dr. Fahmida told me that we also have dihydroartemisinin piperquine available in Pakistan. So the recommended dose for artemether lumefantrine is 3 days, 6 doses in total, and 2 doses should be given, the first 2 doses should be given 8 hours apart. So this is the recommendation for artemether lumefantrine for children 5 kilos and above. So what about the children who are less than 5 kilos? So it is, for them, we use 1.7 mg per kg of mg per kg body weight of artemether and 12 mg per kg of lumefantrine for these children. Duration, just 3 days. Then, new addition. For reducing the transmission of falciparum, because we have seen that they do not causes relapses, but to reduce transmission, we can use, but now we cannot, but we should use 0.25 mg of primaquine along with the ACT. And because it's a low dose and just a single dose, so G6PD is not recommended. And remember, primaquine has its own contraindications. You cannot give in children under 6 months of age, you cannot give in pregnant women, and you cannot give nursing mothers whose infants are less than 6 months of age. So this is a good practice. Just a co-infected children with HIV, तो उनके लिए कहा गया है कि you should not give them Ceftriaxone if they are artemether with artesunate with SP if they are already on Ceftriaxone, or artesunate amodiaquine if they are treated with Zidovudine or other drugs. And now the uncomplicated malaria by other species, the non-falciparum species. We have discussed chloroquine resistance. So what is chloroquine resistance? Actually, it's the persistent parasitemia after 3 days of the chloroquine therapy, or there is recurrent parasitemia within 28 days of treating with chloroquine. This is an old map, but it is telling us that green part is more, green dot is for places who are more than 90% susceptible to chloroquine, the Vivex actually. So if we see, we are here and we are almost more than 90% susceptible to chloroquine. So the first drug for non-falciparum species should be chloroquine. And this is another map which is actually showing efficacy studies, and the orange bars are actually telling us the treatment failures in patients who were treated only with chloroquine, and the blue bars are showing studies that where chloroquine and primaquine were used for treatment and they resulted in failures. So fortunately, unfortunately, हमारी या तो हुई नहीं है studies या हम और इंडिया उन दोनों बाज में हमारे पास नहीं है. So it means chloroquine resistance less in Pakistan, and for non-falciparum species, again I'm saying chloroquine is the drug of choice. And this is what WHO is recommending as well, that in chloroquine susceptible area we should use chloroquine. We can use artemisinin-based therapies as well because it is not easily available chloroquine. That's another issue. Logistic issues हैं, लेकिन recommendations chloroquine की ही हैं. And in areas which are chloroquine resistant, obviously you have to use artemisinin-based combination therapies. And dose of chloroquine is little revised. It is 3 days doses, 10 mg per kg first day, 10 mg per kg second day, and 5 mg per kg on the third day. Total 25 mg per kg per duration of the therapy, that is 3 days. Acha, the new addition in these therapies is actually 2020 में जो आई है कि previously we were giving primaquine for 14 days to prevent the relapse, but now the evidence is supporting that shorter duration is equally effective, and we should go for an shorter duration of the relapse therapy because it has better compliance. So they have recommended that we need 0.5 mg per kg for 7 days. But again, the contraindications are children less than 6 months of age, nursing mothers whose infants are less than 6 months, and the pregnant female. And one more thing, this is a therapy for a week almost, so we should start it after testing for the G6PD and should be monitored closely. And G6PD status should be known. This is again a recommendation, good practice statement है. And there is a conditional recommendation. अगर G6PD deficient है तो क्या उनको relapse के लिए कुछ देना चाहिए? Yes, we can give 0.7 mg per kg per week, just 8 doses and every week. And again, we would have been a regular follow-up because primaquine can cause severe hemolysis in these patients. गुड प्रैक्टिस स्टेटमेंट, अगर हमें पता ही नहीं है मलेरिया की स्पीशीज क्या है, पॉजिटिव तो है लेकिन स्पीशीज क्या है, सो वी हैव टू ट्रीट विद ACT. एंड दैट्स इट. थैंक यू. वेरी अनकॉम्प्लिकेटेड सी प्रेजेंटेशन.